Okay, we'll get started. We're happy to have everybody here today. For those of you who are joining us for the first time, welcome. This is the Trauma and Gender Practice Improvement Collaborative. We've been meeting as a group under this title for a few years now, and mostly through Zoom since COVID. We today are having a presentation on women in the criminal justice system. We had the good fortune of having Dr. Covington participate in our TAG initiative here in Connecticut over many years as a piece of the work we did with the criminal justice folks in the state. We have this video that she did live here in Connecticut that we're going to be showing this morning. And after that, we have a panel discussion of 3 women with lived experience who are going to share their perspective and their own story of recovery and incarceration and how that went for them, and tie it to the film that they're going to be viewing and make comments about what Dr. Covington speaks about. And then we're going to open it for discussion, so participants will have a chance to talk with the panelists. So that's the plan. So first, though, before we kick that off and get started, we usually open up for any announcements. So are there any announcements that folks in the room want to make today?
Good morning, folks. This is Shelley Nolan from Demas. I just wanted to alert folks of a save the date. You may have seen, or we will certainly include with the minutes, that we have a conference specific on women with substance use disorders that will be held on August 26th in our collaboration with Women's Consortium. We have a really great lineup of speakers, and I hope that a lot of you will be able to attend.
Thank you, Shelley. Shelley is my co-host for this meeting. Anything else? Any other agency announcements? So we would be remiss if we didn't mention the Trauma and Recovery Conference that's coming up in October. It is scheduled now for the 17th, 18th, and 19th. This is a holdover from 2020 that has moved multiple times. We've done it virtually, but we're finally able to do a hybrid. So we'll have in person up at the convention center, as well as the ability to do it virtually. So if you don't know about it, we've been sending flyers with most of the notices, and there's information on our website at the consortium. So for those of you who don't know me, I'm Colette Anderson, the executive director here at the Women's Consortium, and we're really excited about today's program. So I'm going to start by introducing Dr. Stephanie Covington, who you will be hearing from first. And as I said to those of you who are on when we first jumped on, following this presentation that Dr. Covington did for us in our Criminal Justice Trauma and Gender Initiative here in Connecticut, we will have panelists who are going to speak about their personal experiences, and we'll introduce them as we finish up the film. The film runs a little under an hour, and then we'll launch into our panel and discussion. So for those of you who don't know Dr. Stephanie Covington, she is an internationally recognized clinician, author, organizational consultant, and lecturer. She is a pioneer in the field of addiction, trauma, and recovery. She has developed an innovative, gender-responsive, and trauma-informed approach that results in effective service in public, private, and institutional setting. Her presentations, staff development seminars, and technical assistance focuses on systems change and the development of caring, compassionate, and empowering therapeutic environments. They provide professional as well as opportunities to learn new skills for dealing with personal, institutional, and societal changes, and are always in demand both nationally and internationally. Sheila, take it away.
Okay, so I'm going to share my screen, and I'm hoping that you guys are going to be able to see and hear this. So just bear with me. And let me know if you're having difficulty. Can you see the screen?
So the piece that I'm going to be talking
Yes, Sheila.
this morning
Thank you.
is particularly talking about women and women with criminal justice involvement, essentially the women that you serve in your various programs. And, you know, I'm just going to spend a very brief bit this morning just to sort of remind us all about what do we actually know. One of the things we know is the United States incarcerates more women than any other country in the world. numbers and percentage-wise to population. So we incarcerate more women than any other country in the world. We actually have the largest women's prison in the world, and it's in California. Something for us to consider. We have over 1 million women who are currently under criminal justice supervision. I mean, the majority of them are in the community. They're under community supervision. But still, it's over 1 million women. But it's over 1 million women under supervision, but about 2 million women are arrested every year. Actually, over 2 million. And what do we know? And this is our national profile of who the women are. Disproportionately women of color, early to mid-30s, most likely convicted of a drug or drug-related crime, so it could be a property crime, but it was property crime involved a way to sustain their addiction. Fragmented family histories with a lot of family members who also have been in the criminal justice system, survivors of physical and sexual abuse, significant substance abuse problems, physical and mental health problems, often unmarried and mothers, limited education and limited vocational training and work experience. So this really describes who you're working with. And I want to make note about this disproportionately women of color. My work takes me lots of places around this country, other countries. Every country that I go to, I ask them, what group of women in your society are most disadvantaged? And then what group of women are overly represented in your prison system? And those groups match in every country. So in this country, it's women of color. In Canada, it's the First Nation women. In New Zealand, it's the Maori women. In Germany, it's the women who've immigrated from Turkey. In the United Kingdom, in England and Scotland, it's foreign national women. So whatever is the most disadvantaged group in any country, that's the group of women that end up in the prison system. So there's something systemic here around the world in terms of women and criminal justice involvement. Histories of abuse. There are a variety of statistics, but what we begin to see is women in the criminal justice system have incredibly high rates of physical and sexual abuse. And they're more likely than men to also report their abuse. We also know there's a very strong link between early childhood abuse and mental health problems. How are they different? What about the women and girls in the juvenile and adult system, and how are they different than men and boys? They have more severe histories of sexual and physical abuse. Studies have been done showing that they're more severe in childhood and also more severe in their adult life, higher prevalence of mental and physical health problems. Their patterns of drug abuse are more socially embedded, meaning they're more connected to relationships. We have many women who begin to drink and use like their male partners, and very few men who begin to drink and use like their female partners. So there's this whole relationship piece with drug use and abuse. They're the primary caregivers, although we have an incredible number of men, obviously, in the justice system who are fathers. It's very often the women who are the primary caregivers or the custodial parent at the time of arrest. Again, limited education, less education than the men, less experience with employment than the men. And they respond differently to both treatment and criminal justice supervision. They also commit fewer violent crimes. And the violent crimes they do commit are different than the violent crimes men commit. So with women, those who commit the most violent crimes, where a life is lost, very often that's a person they know. With men, it could be someone they know or could be a stranger. So we have differences between men and women who have criminal justice involvement. Pathways theory is the theory that we use to try to think about how do women get into the justice system? What are those events? And pathways theory looks at life events that put you more at risk into the criminal justice involvement. It looks at what we call life course theory. And the idea is if you can look at women's pathways or girls' pathways into the system, perhaps it can give us some ideas about their pathways out of the system. My colleague Barbara Bloom talks about triple jeopardy, the impact of race, class, and gender on women. Other colleague Barbara Owen talks about marginality, that so often the women and girls live at the margins in terms of communities and schools and work and so forth. And the focus of my work has been trauma and addiction. So these are what we see as the life course events that increase a female's risk of criminal justice involvement. And then we think about reentry, right? Everyone's talking about reentry now, What is it that people need for those who've actually been incarcerated? Certainly she needs a place to live, she needs food, she needs clothing, and she needs money. She's supposed to stay sober, abide by the law, take care of herself, care for her children and her family, comply with the conditions of her release or probation or parole. Her other pressures are the expectations of family members, family violence and the lack of domestic violence resources, the untreated trauma, the problems with mental health, lack of parenting models, lack of education, employment, the prejudice against ex-offenders in the workplace, issues around immigration, and in many places the inability to vote. So there's a whole variety of things when you're working in your agencies that are really complicated when you begin to think, particularly I think about social services and particularly about what women need. The interesting thing is a number of years ago, Drs. Barbara Bloom and Dr. Owen and I did a project with the National Institute of Corrections, and in that project, which was about a 3-year research project, we were to write guiding principles for working with female offenders, and we did lots of focus groups with staff, with the women themselves. And I'd go in a focus group of women who were in various prisons around the country, and I would ask them, what did you need in your community that might have prevented you from coming into this institution? And then what the women said they needed, what did they need? They needed housing, they needed a job, they needed domestic violence services, they needed substance abuse treatment, they needed all the things we now talk about for reentry, but we wouldn't even consider giving them up front before they got to prison. So as we focus on reentry, all of those things that we're trying to provide now are actually all the things that they needed before. A little short-sighted. Yeah. So we look specifically at trauma histories for women. They have much higher rates of childhood and adult trauma exposure than women in the general population. When we begin to talk about trauma and abuse over the course of the lifespan, we see, of course, that this is probably the most abused group of women in our society, are those who have criminal justice involvement. And their trauma history is very much associated with their alcohol and drug abuse, with being a sex worker, with having physical and mental health problems. So a lot of high-risk behavior is connected to this early history. And then, as Eileen mentioned earlier, criminal justice involvement itself can be a re-traumatizing experience. It's traumatizing for those who've had no trauma and re-traumatizing for those who have. So you begin to see that this whole issue permeates every piece of working with women in the system. And the standard operating practices of the criminal justice system actually are some of the major problems in terms of re-traumatizing people. So if you take a woman who has a trauma history and what happens to her when you cuff her at the time of arrest. How about a PAT search? How about a cavity search? How about putting her in a 4-point restraint? Let's take a woman who was raped and now let's restrain her. How is she going to react to that? You know, different states have different rules about this, but it was 2 years ago in California that we finally changed our legislation in California that no longer can male correctional officers pat search a woman. Now just think about that experience and then think about it for a trauma survivor. That has actually been an international regulation and requirement since the early 70s, but the U.S. never signed on to the agreement about not having cross-gender PAT searches. We wouldn't sign that agreement. I don't think we've signed it yet at the international level, but states have different rules about this. So there are many things that very fundamentally in the criminal justice process have an impact on women who have a trauma history.
I appreciate the sensitivity re-traumatizing even if
Oh.
I mean, and I know that's implied, but, you know, just the fact that, and I also understand that from the criminal justice or the law enforcement perspective, it's a safety issue, you know, in terms of patting down to make sure there aren't weapons, etc. But whether it's a man or a woman, you know.
And there are ways to do it.
Exactly.
We all know this from the airport, right? If they decide that they're going to give you a pat search in the airport, different people pat search you differently in the airport. So you imagine what they do in the criminal justice system, where they have even less respect for you. Yeah. And it also makes a difference the person who's doing the search, depending on, you know, now at least in the airport, they don't have men doing pat searches on women. At least they got that piece. But in the criminal justice system, not necessarily. Yeah. So basically, when we look at the world we live in and work in, and particularly the criminal justice world, what we see is lots of abuse and trauma, just in multiple ways. And one of the ways I think about this, when I think about suffering, is I divide it into two categories, what I call natural suffering and created suffering. And for me, natural suffering can come from two places, really. It comes from being involved in a natural disaster, an earthquake, a fire, a flood. And it also comes from the experience of just being born and growing up and getting older, and things happen in life. Things that are challenging, things that are painful. But I do want to contrast that natural suffering to created suffering. And created suffering comes from the atrocities that human beings do to each other. And I don't believe there's anything natural about that. And so when we're basically doing our trauma work, I think we focus more on the created suffering, because the dynamic is very different. When there's natural suffering, like a natural disaster, it's public information. People hear about it, people know about it, people rally around to help. When there's created suffering, it's always surrounded by silence. Whether it's something very large like the Holocaust, that was originally covered up by silence. If we look at what happens in families, covered by silence, childhood sexual abuse. So there's a very different dynamic that happens, and it's more difficult for people to heal from created suffering than from natural suffering. And part of it is that isolation and that aloneness and the lack of help. And
Typically, too, in natural suffering, there's more than one person experiencing
exactly,
it.
exactly.
So it's a widespread event.
Much bigger.
Where there's natural, you know,
Right.
support and natural empathy.
Right.
Because you all have an appreciation of
Right.
what's going on.
You don't feel so alone. There's not that sense of isolation. So it's to think about the suffering involved, but also I like this quote from Helen Keller that although the world is full of suffering, it's also full of the overcoming of it. And so it's really about, there's also a tremendous amount of resiliency that people have. And so when we talk about women in the criminal justice system and their overwhelming histories, and, you know, I've done this work for a long time, both in clinical settings as well as criminal justice settings, and the most horrific stories of trauma that I've ever heard come from women in criminal justice settings. And while that is true, there's also, it's amazing their ability to survive and the kind of resiliency that's there. So our challenge in working with people is how do we build resilience? That really is, I think, what we try to do. The definition of trauma, you know, Eileen and I have used the word a lot, has actually changed over time. Initially, when people began to talk about trauma, and the first time it was in the DSM, the Diagnostic Manual, it was about an event. Then we began to learn, no, trauma isn't just an event, trauma is also a particular response to an event. And in the new DSM-5 that came out a couple of years ago in 13, they added a new piece to it. So the definition, the technical, clinical definition today is it's still an event, a threatening event. And you can either experience the event directly, so you can either experience it or you can witness it happening to somebody, or you can learn that it's happened to somebody you care about and love. And the new piece that's added is this piece about firsthand, repeated, or extreme exposure to adverse details. So this was added because of the understanding about what happens for people who work with trauma survivors? What happens to people who are counselors or in a position where you hear people's stories over and over, hour after hour, day after day? That can impact you. Or if you're a first responder to a traumatic event. So this piece has been added to the newer definition. But it's not just the event, it's also the response to the event. And so it has to sort of cause some sort of difficulty in people's social interaction with each other or their ability to work, to function. And years ago, we thought that if anybody experienced the same event, that meant they were traumatized. But it really was what happened in New York City 9/11 that really had us look at the fact that now millions of people experienced the same event, and there was a whole range of responses. The responses to the same event are very different. They're not all the same. In that example, some people had what we call an acute traumatic response. 30 to 60 days, their lives were turned upside down. And over time, things came back to some semblance of normal. There's some people, though, today that are still struggling with that event. So it's not just the event, it's the individual's response to the event also. Here's a simpler definition: when an external threat overwhelms a person's coping abilities, both their internal and external coping abilities. So something external is so overwhelming that you can't function in the same way. So when we think about events, we've learned also that this can take just a whole range of things, right? There's the emotional, sexual, physical abuse, neglect, abandonment, particularly for kids. What about frightening medical procedures or being involved in our healthcare system? And that can be traumatic for people. Rape, muggings, domestic violence, automobile accidents. How about immigrating to this country? For many people, that is actually the trauma. And for many people who come to this country, they come here to get away from horrible things that are happening in their country of origin, and they come here with an idea of this is a place of safety, and that's not what they experience. Not what they experience. There's the terrorism, the witnessing violence of what happens in homes, losing a loved one, war, torture, kidnapping. The trauma of stigmatization. This is one we don't talk about very much. So trauma can happen in all these various ways. And then what happens when you're stigmatized? You belong to a group of people that in our society are seen in a very different way. And I'm just going to read you a piece that I think helps bring this to life. And this was written by the late Audre Lorde, and she was writing about her experience growing up in New York City as an African-American child. Okay? The AA subway train to Harlem. I clutched my mother's sleeve, her arms full of shopping bags, Christmas heavy. The wet smell of winter clothes, the train's lurching. My mother spots an almost seat and pushes my little snow-suited body down. On one side of me, a man reading a paper. On the other, a woman in a fur hat staring at me. Her mouth twitches as she stares, and then her gaze drops down, pulling mine with it. Her leather-gloved hand plucks at the line where my new blue snow pants and her sleek fur coat meet. She jerks her coat closer to her. I look. I do not see whatever terrible thing she's seeing on the seat between us. Probably a roach. But she's communicated her horror to me. It must be something very bad from the way she's looking, so I pull my snowsuit closer to me, away from it too. When I look up, the woman is still staring at me, her nose holes and eyes huge. And suddenly I realize there's nothing crawling up the seat between us. It is me she doesn't want her coat to touch. The fur brushes past my face as she stands with a shudder and holds on to a strap in the speeding train. Born and bred a New York City child, I quickly slide over to make room for my mother to sit down. No word has been spoken. I'm afraid to say anything to my mother because I don't know what I've done. I look at the sides of my snow pants secretly. Is there something on them? Something's going on here I don't understand, but I will never forget it. Her eyes, the flared nostrils, the hate. So this is the trauma of stigmatization. This might have been 5-10 minutes in the life of a child. And of course, she goes on to give us many more examples. And I think we often forget or discount or don't pay attention to the trauma of stigmatization. So basically, in the population you're working with, there's the trauma of stigmatization that comes on multiple levels. There's the stigmatization of being in the criminal justice system. That alone can be traumatic, not just by policies, but by how our society sees people. The other area we've begun to understand more about is intergenerational or cultural trauma. And this is really what happens to groups of people where there's an accumulation of the wounding that's happened in generations that gets passed along. And people began to learn about this first by studying the Holocaust and families who had gone through that experience and seeing what had happened generationally. And now we see, of course, right, in our country, Native American population, African American population, the Japanese families who were put in internment camps on the west coast of California and Canada. Canada's the First Nation, and people in New Zealand, it's the Maoris and so forth. And so we're looking at what happens over time. Now, of all these forms, different kinds of traumatic events, both men and women experience them. I mean, they're experienced by males and females. However, when we look at the interpersonal violence and intimate partner violence, that's where we see women have higher rates of abuse than men do. So this becomes one of those differences. And so let's look at some of the gender differences. And I think one of the first things, both Eileen and I are talking, we're basically saying male and female, but also when we begin to talk about gender, and you mentioned this, and it's really looking at this along a continuum. This really is no longer a binary situation. And when we talk about our transgender population, we see another group of people who've been significantly traumatized. Now, particular complication is for transgendered people with criminal justice involvement. In most states, I don't know Connecticut actually, it's a gender by, right, so it's gender by sex organs.
Right.
Yeah, not by how you live,
Right,
yeah.
that's how-
Genitalia determined, okay. Well, this is really problematic, right? Because how we want to be providing services to people as per the gender they are living. So if someone has transitioned from male to female, then we want her in a women's group. But in the criminal justice system, in most states, it is determined by genitalia, but fewer people are having the surgery and making that total transition for a variety of reasons.
Well, and one of them, if you look at the people, if you look generally at the population of people who fill most of our prisons, there's not just racial disparity and overrepresentation, but class.
Oh, yeah.
And so, this is not something that's typically covered by insurance or Husky D, for sure.
Right.
So it's a financial issue too, in terms of people being able to follow through with the surgery, even if that's really what they want.
Right, yeah. Yeah, so there's a huge financial piece. So when we look at trauma and think about some of the differences in terms of males and females, if you look over the course of the lifespan. So in childhood, you have both male and female children that are high risk for physical and sexual abuse. And of course, the greatest risk comes from family and from people they know. But we begin to see the differences as we move through the course of life. So if you move into adolescence, a boy who is gay or a boy who is a young man of color, his risk for abuse comes from people who dislike him, his peers and the police. If he belongs to a gang, his risk for abuse comes from the oppositional gang. Contrast that with the teenage girl. For the teenage girl, her greatest risk for abuse comes from her relationships from the person to whom she's saying, I love you. You move into adult life. If a man serves in the military in this country, his greatest risk for harm comes from the enemy. If he's living not in our prisons, but in the free world, in our communities, his greatest risk for harm comes by being a victim of crime committed by a stranger. For a woman in her adult life, if she serves in the military, her greatest risk for harm comes from the men she's serving with. If she's living in our communities, again, her greatest risk for harm comes from her relationships from the person to whom she's saying, I love you. So when we work with a man who's been abused, it is very unusual to work with a man who was abused by someone he was in a relationship in his childhood, someone he knew, and then in his adolescence he was abused by someone he was in a relationship with, and then in his adult life was abused by someone he was in a relationship with. It happens, but it's rare. For women, it's very common. Very often when you work with women, they were abused in their childhood by someone they knew, they were abused in their adolescence by someone they were in a relationship with, and they were abused in their adult life. And this has implications for the services we provide. It has implications in terms of her level of trust, and it has implications when we think about who's going to be her counselor, what kind of group process she should be in, and what are the issues you're going to be working on in the process of group. So we definitely have gender differences in terms of risk. And what we see when we look at the world of women, and particularly women in the criminal justice system, are the reoccurring themes of trauma and abuse. Those are just themes throughout their lives. This is a study that was done by my colleague Shelley Brown in Canada, and I really love showing that. Kelly's a very good researcher. Worked a lot with criminal justice, used to work with women and works now more with girls, professor, but really never bought the gender piece. And so every time we'd have lunch or dinner periodically, we'd see each other, this would be a point of discussion. And I'd be trying to convince her and she'd be telling me, forget it. Well, then recently she did a study on juveniles in the Canadian juvenile justice system. And she added this question to her, to the data she was gathering. And she was asking them if they'd ever been raped or in danger of being raped. The girls, 47%. The boys, 6%. And the next time I saw her, she said, well, I've changed my mind. I've decided that gender does make a difference, that these are different worlds. Okay? Yes?
I actually read something, and it may have been something you were a part of when I was looking for some male-specific gender stuff. Women tend, when they get incarcerated, they tend to get away from the abuser or traumatized person. Men are going into actually an equally traumatizing place, if not more dangerous.
Right.
So
Yeah.
that's a clear difference. It may have been something.
Yeah, and it is, well, women going into custodial settings will often say things like, I feel safer here, because they are getting, and not that all women's prisons are safe, I'm not that naive, but the level of risk actually for many women decreases. When men go into a men's prison, one of their greatest fears is abuse inside the facility. Right. So it's a different experience, yeah. And I always think anytime a woman says to me, you know, this is the first time I feel safe, and she's been in prison for 10 years, my heart sinks. I mean, to feel safer in prison than you do in a community, I mean, what does that say really about women's lives and about our communities? Not a good thing, yeah.
An additional thought that I had.
Uh-huh.
We're going back to the frequency of women that are at greater risk of interpersonal abuse, or interpersonal violence.
Right.
Than men. But I'm thinking about all those children who are in those homes,
Yes,
who are just as likely to be male as female.
right,
They're growing up in an environment where they're witnessing
yes,
abuse, and I know that, or at least I believe I know that that can be one of the most damaging forms, or most
Yes, it's very difficult for children to observe parental abuse. Now, interestingly, a study was done a couple of years ago in a women's prison, actually in Northern California, where actually for a period of time we supposedly had a trauma-informed prison, and they of course closed it. But you know, let's do something new, radical, it's working, and now let's close it. But anyway, during the period of time that it existed, one of the studies done there by a colleague at UCLA had the women look at all their traumatic, they listed all the various traumas they'd experienced, which of course was started in childhood and so forth, and then had them rate them as to what they thought was most traumatic. And we were really surprised at the results. Do you know what the women said was most traumatic? We had childhood sexual abuse, we had losing a loved one, there were automobile accidents, there was domestic violence, there was all kinds of stuff. What was most traumatic?
Witnessing their mothers being beaten.
That's what we had expected. No. Childhood sexual abuse, witnessing their mothers being abused. No, it was domestic violence, and we were all really surprised. So went back and did more interviews with the women, right? Because it wasn't, we were like, well, really? Do you know what it was? The childhood sexual abuse is over. I'm no longer in the home where my mother's being battered, but the domestic violence will probably go on the rest of my life. The sense that they will never be safe. And that's the most traumatic.
Understand?
Now, it makes sense hearing it from them, but it was not what we expected at all. It was the fact that they've been in relationships with domestic violence, and even if they change partners, there's a belief that this will always be part of their life. So it was not our anticipated result at all. So again, different worlds. The place that really began to look at services for women was substance abuse treatment, not mental health and not criminal justice. And it really came out of the women's movement in the 60s and 70s. As women came together in consciousness-raising groups and told the truth about their lives, people began to hear about childhood sexual abuse. They began to hear about abuse of alcohol and other drugs. They heard about unwanted pregnancies. They heard about all kinds of things. Heard about domestic violence. And because of that, we often have forgotten today that most of our social services today actually came out of what we learned in the women's movement. We got our first DV shelter in the 70s. Not because there was no domestic violence before then, but because people talked. The whole understanding of childhood sexual abuse. And I often share with people, you know, my first experience in graduate school was in the 60s. School of Social Work, Columbia. So it was a good school of social work. And this is my training on trauma. Master's level program, right? It's short, it's 2 sentences. One sentence is, incest occurs in less than 1% of American families. And the second sentence, and the majority of them live in Appalachia. And that's what people believed. And the women's movement, with women talking about their life experiences, people had to begin to take all this into consideration. So not only did we get our first DV shelter in the 70s, we got our first women's substance abuse program in the 70s. And it was federally funded. The feds funded 10 or 12 demonstration projects around the country and began to talk about the gender differences, and people began talking about gender-specific services. And I can tell you from visiting programs, that looked different every place. Some programs thought that, as Eileen said earlier, that if you just separate the men and women and put them in separate groups, that's gender specific, but you give them all the same material and everything is, no, that isn't what we had in mind. And so now we talk about being gender responsive. How do you actually respond to the issues that are related to a person's gender, whether it's male, female, trans, whatever. And you really cannot be gender responsive unless you're trauma informed. The definition you saw from Eileen before, but I just want to really reiterate, it's about environment as well as content. And sometimes people get very focused, okay, these are our program materials and this is what we're going to do. I write the stuff, I think it's important, but it's not the be-all, end-all. It's really also what's happening in the environment, right? And thinking about all these, and that's really what being trauma-informed is about, is much more about the environmental aspect. And initially, what we did is we talked about women and girls. And today, this whole definition now has been expanded to include men and boys. But being responsive is really not only about the differences and saying, well, this one's this way, this one's that way, this one's this way. It's really about using research on women and girls to guide what we do. And then research on men and boys to guide what we do, not always comparing and contrasting the two. And some things will overlap, but really looking at what we know. Finally, we have because I've done this work for a long, long time, and people say, well, I don't think it really makes any difference. We've had anecdotal information for years about the differences. But finally, there's been a published research study following, for 10 years, a longitudinal study, following women who were either in women's only treatment or in mixed gender groups, and to see whether it actually made any difference long term. And what we have found out is the women who are in the women's only services, 10 years later, less alcohol and drug abuse, fewer mental health problems, and less involvement in the criminal justice system. So a 10-year study trying to show us that, in fact, this all does make a difference. So let's look at what actually happens to folks. So you have a traumatic event. It overwhelms physical and psychological coping skills. And I want to also emphasize physical, and we'll talk more about that because we get very focused on the psychological piece. You have the initial response to trauma. People talk about fight, flight, freeze. With women, we also add faint. So there's some immediate kinds of responses. And you end up with a person with a sensitized nervous system, changes in the brain, and the brain-body connection. This is not just the mind-body connection we've always talked about, but as our brain scans have become more sophisticated, we now understand that as the brain is changing, that actually has an impact on physical responsiveness. So you end up with someone who has some physical and psychological distress, and these could be current stressors, like being arrested, being put into jail or prison. It could be a trigger. Triggers are reminders of the trauma. They come from body sensations, they come from thoughts, feelings, smells, someone's behavior, their behavior, memory. Can come from a whole variety of places. And then we see our emotional and or our physical responses to all this. The retreat responses of what we might consider our mental health responses, the isolation, the depression, the anxiety, the dissociation, the mind-body split. PTSD is one form of anxiety disorder. The harmful behavior to self, here we have the substance abuse, eating disorders, self-harming behavior, suicide attempts. The harmful behavior to others, here we have the aggression, the violence, and the rages. And then we have physical health issues. So all of these things that happen in people's lives here, in many cases, are linked back to here. And so in my mind, it makes no sense to provide mental health services unless you have a trauma lens. It makes no sense to provide substance abuse services unless you have the lens of trauma. And this, I can tell you, anger management programs do not even touch what's over here. And they were never designed to. They don't have a trauma foundation. And we see a gender difference here, that women more often do this box, and men more often do this box, harmful behavior to self and harmful behavior to others. Both end up with health issues. So I'm not saying there are no men over here with mental health issues any more than I'm saying there are no women that are aggressive. I'm just saying in general that when there's anger, more often women turn it inwardly and more often men turn it outwardly. So one of the studies that's been done is the ACE study to really help us understand some of these interconnections and the power of this. How many of you are familiar with this study? Okay, a couple of you. Okay, I'd like you to make 2 lists, maybe in your toolkit or on a piece of paper, from 1 to 10. So if you'd make 2 lists from 1 to 10, and I'm going to give you the 10 ACE study questions. And ACE stands for Adverse Childhood Experiences. And when this study was originally done, it was done in San Diego. And 17,000 people responded to a questionnaire that had 10 questions about their childhood. Okay? So here are the 10 questions, and I'd like you to answer them yes or no twice. One list is for yourself. So if you'd answer the questions about your own life experience, and then the other set of 10 are pick a typical client, male or female, and answer how you think a typical male client in your agency or a typical female client in your agency would respond to these questions, okay? Okay, all before age 18. Did you experience recurrent severe emotional abuse? Yes or no for yourself? Yes or no for a typical client? Recurrent severe physical abuse? Again, answering for yourself and for a male or female client. Contact sexual abuse? Emotional neglect? Fifth question is physical neglect. Before age 18, did you grow up in a household where both biological parents were not physically present? Out-of-home placement, foster care, separation, divorce. Question 7, was your mother being treated violently? Did you grow up with an alcoholic or drug-using family member? And answering twice. Question 9, did you grow up with a mentally ill, chronically depressed, or perhaps a family member who needed to be institutionalized? And question 10 is a family member who was imprisoned. So how you score this is you count 1 point for each yes answer. So you're going to have a score from yourself from 0 to 10, and you're going to have a score for a typical client, 0 to 10. I'm not going to ask you your personal scores, but I would like to hear some numbers. If you tell me if it's male or female client and then the number you came up with. So give me some numbers. Female 10. Male 9. Male 10. Male 9, 10. Male 8. So if I say 4 or more, I'm going to pick up all your clients, right? 4 or more. I've got everybody. I've got all your clients. And if I say 4 or more, I'm picking up most of you. Maybe not all of you, but the majority of you. My guess. Okay? So let's look at what they learned from this study about what happens when there are 4 or more yeses. Initially, they looked at smoking, alcoholism, and the injection of illegal drugs and obesity. And they found that people who had a score of 4 or more yeses, 30, 40, 50 years later in their lives, looking at what would happen before age 18, were the people that were struggling with 1 or more of these issues. Then they went back and they looked at chronic health problems. They looked at heart disease, autoimmune disease, lung problems, liver disease, sexually transmitted infections. And they found that people who were using most of the healthcare services that had chronic health issues were people who had a score of 4 or more. Okay. That they could begin to predict by early childhood experiences who was at risk to have physical health care problems. So, there's so many interesting things to me about this study. Number one, the study was originally done at the end of the 90s. And for 12 to 15 years, no one even paid any attention to it. The Kaiser Center that did this, with help from the Center for Disease Control, our federal agency, published the paper, original paper. No other Kaiser Center ever picked up the questionnaires or used it. It got no traction. It's gotten so much traction in the last 3 to 5 years, it's amazing. Translated in 26 languages, all different kinds of things. But nobody paid any attention because that really was pretty much our attitude about trauma. It was, yeah, so. But now we're beginning to think about what it really means for people. The women were 50% more likely than the men to have a score of 5 or more. So there was a difference here. The people with high scores were given 1 hour with a mental health professional. They didn't want to overdo it. And those 1 hour sessions started with this statement: I see you have experienced whatever they checked off on the survey. How do you think it's impacted your life? How do it impacted you later in your life? People were amazed to have been asked the questions. There were all kinds of responses. One man said, you know, I've never discussed this since I was 5. I tried to tell my mother and she said it didn't happen. Those things don't happen in our family. 78-year-old woman said, I thought I'd take the secret to my death because no one ever asked, so I figured nobody cared. People asked, how come you're asking me now? And they were amazed that people said, because we think there's some connection between what's happening now in your life and when this happened. The staff at Kaiser did not want to be part of this research project. They pushed against it and said no. They said, we don't have enough mental health services to deal with all the people that are going to have meltdowns. Okay? They did not want it. So one of the things they did is a staff person carried a pager. A pager was carried 24 hours a day, 7 days a week for 3 years, so that any person that answered this questionnaire that had a difficulty could call and get some assistance. 17,000 people responded to the survey. How many phone calls did they get? How many phone calls did they get? 0. The only people that melted down were the staff. So afraid of going into this. So afraid of talking about it. So afraid that everybody was so people had already survived it. They've already survived it. They've lived it. They've survived it. I think the other reason the staff was having a meltdown is a lot of this was too close to home about the things they had never talked about and never shared. And it's why it's really, really important that this project, while it's going to be focusing on your clients, is also focusing on staff. Because it isn't about us and them. It's about everybody. And the places you work have an impact on you, and the work that you do has an impact on you. So the folks with the ACE study talk about we have adverse childhood experiences, it disrupts neural development, you end up with people with social, emotional, and cognitive impairment, they adopt health risk behaviors, we end up with disease, disability, and social problems, and up here is early death. For people with high ACE scores, it decreases their longevity by 19 years. 19 years. And if you're interested in more information, there are 2 really good websites. ACE is Too High. They'll send you emails a couple times a week with all kinds of things that are happening around the country, using the idea of becoming trauma informed and using the ACE study information. This has the more technical academic papers on it. This is really easy to access information. So that's where you can get more information. 2 colleagues from UCLA, I mentioned earlier, do a lot of work with women in prison, Nina Messina and Chris Grella. They took the ACE questions in 2000 into the women's prisons in California and asked the ACE questions to the women there and basically got the same results. that the women with the higher ACE scores were the women in the Medline that had the chronic health problems and were struggling with physical health. Biggest impact was on mental health. The women with the higher ACE scores, more psychotropic medication, more attempted suicide, much more traumatic stress. And look at this number. If a woman had a score of 7 or more yeses, it increased her risk of a mental health problem by 980%. Hardly by chance. Hardly by chance. Another correlation that's really high is that if a man has a score of 6 or more yeses, his risk of being an IV drug user is 4,600% greater than someone who has an ACE score of 0. Again, hardly by chance. Many people begin to use alcohol and other drugs as a way to deal with the symptoms they're struggling with that are attached to early trauma experiences. So I think Eileen's talked about being trauma-informed, trauma-specific, right? Trauma-specific is what we do with clients. Trauma-informed is how we do business. 3 key things are important both for staff and clients. Same basic 3 things. All staff need to learn what trauma is and what abuse is, and our clients need to know that. Even though they have these histories, often people don't know how to label it or identify it. Or it's been so pervasive in their community and their families, they think this is just how life is. So we teach people how to understand this. To understand typical responses. You know, when I'm helping women in prisons understand post-traumatic stress disorder, I invariably get comments like this, like, you mean people know about this? Yes. You mean there's a name for it? I just thought I was crazy. I've been hiding this for years. Okay. So we help people understand, you know, that process of trauma chart. Eileen started using that in a women's prison in York in a healing trauma project. And I actually hadn't included it in the material, actually, because I used it in training. I didn't include it in the material for it, but Eileen liked it. She took it into the prison at York. The women really responded to it, so we've added it now in newer curricula because it helped them understand their lives. They said, oh, now it all makes sense. This happened, and then, yes, I felt like this, and oh my. And then all these things that I can link back, and I understand my life better. And then coping skills. We want people to develop coping skills so that whenever they're triggered, they have some way to cope with that. Staff need coping skills. Our clients need coping skills. So these are the 3 fundamental things. The model I use with women, I call it Women's Integrated Treatment. The acronym is WIT, which means don't lose your sense of humor while you're doing this work, even though it's hard. And it's based on the definition you've been given. There's some guiding principles, there's theory, and then strategies that are all kinds of different things. The definition you've seen. These are the guiding principles that come out of that 3-year project with the National Institute of Corrections for working with women. And the first principle is gender. You have to acknowledge that gender makes a difference. If you don't acknowledge that gender makes a difference, you're never going to get the really best services for men or women. You have to acknowledge this. And you'll see environment is right there. Have an environment placed on safety, respect, and dignity, and how challenging that often is with criminal justice settings. And then we have things about relationships, integrated services, socioeconomic status, and of course how important it is to have a system of services in the community, which you're all trying to provide. Theory is what grounds our work, and our treatment, what we actually do with people, the strategies, comes out of our theory. This is how we build programs, how we take theory and make it work. When we think about treatment strategies for trauma, there are a variety of things that we use. People historically have been very focused on cognitive behavioral interventions. Part of the reason for this is the best researched, and it's the best research because it fits our research model the best and easiest. A number of years ago now, Bessel van der Kolk, who's a major trauma person, was, I think, in Pennsylvania at the state psychological annual meeting, and asked, he had an audience of about 700 people, and he said, how many of you are using cognitive behavioral interventions to treat trauma survivors? And, you know, me. And he said, well, you're all doing it wrong. And everybody quickly pulled their hand down, feeling somewhat less pride in their practice. But what he said is, what we've been learning is that you have to use a variety of responses, and it's actually the mind-body, using a different side of the mind, that's actually most important. He said you have to use art, and you have to use movement, and you have to use all these other things, which many of us have known for years anyway, but we haven't had the research behind it. But you get someone big like him saying it, it gives you justification. But we use some of this, yes, but guided imagery, relational therapy, mindfulness, EMDR, the eye movement desensitization and reprocessing, emotional freedom technique, EFT, the expressive arts, mind-body things like yoga. So there's a variety of things we use when we're working with people who are trauma survivors. This is the long list of things I've written. There's a bunch of stuff, some on substance abuse, some on trauma. Something for girls, training curriculum for correctional professionals. It's a day-long training, 12 steps. The newer material, Beyond Violence, is for criminal justice involved women who've committed violent, aggressive crimes. And this is for women in the community who have issues with anger. Self-help books, Relationship, Sexuality, 12 steps. When we look at trauma-specific interventions that are also gender responsive, there's not a lot out there, okay? I've written 2, Beyond Trauma, 11 sessions, Healing Trauma 5. This is what's been, the consortium's been very involved at York, providing this to women at York. Trauma Recovery Empowerment Model written by Maxine Harris. When we look at trauma-specific materials for men, Helping Men Recover has a trauma piece in it. The men's version of the Trauma Recovery Empowerment Model, Roger Fallett's. And then I'm working with Rob. We're working on Men in Trauma, which will be a 6-session brief intervention for men. And that's actually written. Now we're polishing it and ready to pilot it. So the pilots will start in a week or 2. So benefits of becoming trauma-informed, when we particularly think about criminal justice-involved women, high prevalence. The correctional facilities are often significant triggers. Evidence suggests that a lack of trauma-informed practices really has a negative effect on women's mental health and their ability to be successful. And what we find is if you create a trauma-informed culture, it increases safety, not just for our clients and the women, but also for staff. So in closing, I want to suggest to you the way that over the years I sort of see this is I think the women in the criminal justice system really represent the issues that are in all women's lives, except we see them all magnified. We just see them in much greater proportion and at a much deeper level. So thank you.